Bismillahirrahmanirrahim. The topic I'm going to speak about today is peripheral neuropathy or peripheral polyneuropathy. Before we start, this is the diagram to state a neuron. A neuron is the unit of the nervous system, whether it's the central nervous system or the peripheral nervous system. It is formed of cell body containing most of the cell organism, large number of cell processes called dendrites that connect the neuron to the adjacent neuron, and large central process called the axon. The axon is surrounded by an outer layer called myelin sheath, which appears in black, an outermost layer which is the Schwann cell layer. Both the myelin sheath and Schwann cell layers are not continuous layers. They are interrupted at what we call the nodes of von Wien. The function of the axon is the transmission of the impulse in one way, from the neuron into another neuron in case of neural junction, to a muscle in case of neuromuscular junction. Transmission of the impulse occurs in two ways. The first way is through the axon, or what we call axonal transmission. We can see here that the axonal transmission is relatively slow. The other way of transmission is through the nodes of von Wien, or what we call saltatory conduction. Saltatory conduction, this is a transmission of the impulse through the nodes of von Wien. We can see here that the transmission is much faster. Why I am bringing this slide? To demonstrate them. When there is a damage to the peripheral nerve, we can differentiate between two pathologies: axonal neuropathies and demyelinating neuropathy. Axonal neuropathies in which the axon is damaged with relative preservation of the myelin sheath. So the axonal transmission is lost, but the saltatory conduction is still present. So in this case, the conduction velocity is not affected or is not much affected. It appears normal or slightly reduced. The other type of pathology is the myelinating neuropathy, in which the axon is preserved, but the myelin sheath is lost. So the saltatory conduction, which is the faster conduction, is lost, as the axonal transmission is preserved. So the conduction velocity is markedly reduced. By the word marked, we mean that there is reduction of 30% or more below the lower limit of the norm. Demyelinating neuropathies, axonal neuropathies, most of the diabetic neuropathies, toxic neuropathies, metabolic neuropathies are axonal in nature. On the other hand, for demyelinating neuropathies, the only thing I want you to remember is demyelinating polyneuralgic neuropathies or Guillain-Barré syndrome. This is the diagram to demonstrate how the peripheral nervous system is formed. It starts by two spinal roots, anterior spinal root or ventral root or motor root, posterior spinal roots or dorsal roots or sensory root. Both spinal roots unite together in the intervertebral formula to form the spinal nerves. The spinal nerves this pass into plexus, and the plexus gives off peripheral nerves. Some definition I want you to remember. When you are confronted with a patient with acute onset of West-Doppler, this is an impairment of function of individual nerve, which is the axial nerve. When you are confronted with a patient with facial nerve palsy, this is an impairment of function of individual nerve. Foot Doppler, an impairment of function of individual nerve with the common peroneal nerve. So this is what we call a mononeuropathy. And the pathology in this case is usually localized pathology, whether it's trauma, it's entrapment or compression, or localized inflammation. On the other hand, if you are confronted with two or more individual nerves, for example, ulnar nerve on the right side and left side, ulnar nerve on the right side and the common peroneal nerve on the left side or on the same side, this is what we call multiple mononeuropathies or mononeuritis multiplex. So it can be defined as it's a simultaneous or sequential involvement of two or more individual nerves, partially or completely, evolving over a period of days or 2 years. The pattern of involvement is usually asymmetrical. So even if the patient has ulnar nerve on both sides, usually they are not to the same extent. One of them is severe and the other is mild or moderate. So the pattern of involvement is usually asymmetrical. But as the disease progresses, the deficits becomes more confluent and may appear like it becomes more and more symmetrical and may simulate peripheral neuropathy. So then we came to the peripheral neuropathy. Peripheral neuropathy, as we mentioned, means impairment of the function of all peripheral nerves simultaneously and symmetrically on both sides. simultaneously and symmetrically on both sides, with involvement of both motor and sensory fibers of the distal segment of the peripheral nerve. So, mononeuritis is asymmetrical, but peripheral neuropathy, it means impairment of all peripheral nerve simultaneously and symmetrically on both sides. So, the cause in this case must be to be a systemic, like diabetes, like uremia, like renal failure, like systemic inflammatory process. So, what are the characteristics of polyneuropathies? Now we understand that polyneuropathy is not a diagnosis, but it's a localization of the pathology to the distal segment of the peripheral nervous system, which has many causes that we are going to speak about later. So the first step of the diagnosis is to diagnose the case as a patient of polyneuropathy and localize the pathology of the distal segment of the peripheral nervous system. So the onset may be acute or subacute or gradual according to the cause. In case of Guillain-Barré, it is an acute. In case of uremic or in case of toxic or in case of hereditary neuropathy, it is gradual and progressive. This involvement of the peripheral nerve, which has both motor function and sensory function. So motor function, we choose this weakness, which is symmetrical bilateral. You affecting usually the lower limbs, then the upper limb. Usually the lower limbs are early and more severely affected compared to the lower upper limbs. Why? Because the fibers runs a longer course. So the weakness is symmetrical bilateral, distal more than proximal. As a result, there may be foot dope, S-dope, and high steppage gaits. The weakness is of lower motor neuron type, so it is associated with hypotonia. The deep tendon reflexes are reduced or absent. The superficial reflexes may be lost if there is involvement of the reflex arm, but the blood response, if it is present, it remains flexo. It is not extensor, it remains flexo. Sensory manifestation may be subjective or objective. Sensory manifestation may be subjective or objective. Subjectively, the patient may complain of paresthesia, complain of numbness, tingling sensation, pins and needle sensation, usually in the distal parts of hands and feet. They may also complain of pain and cramps. Objectively, there is loss of pain and temperature in the distribution of glove and stocking. By the word glove and stocking, we mean that it has to be symmetrical and bilateral. Right side exactly like left side, medial aspect is exactly like the lateral aspect. There may be also affection of the deep sensation, sense of the joint sensation and sense of position, so there may be a sensory ataxia. Some of the cases be associated with autonomic manifestation, especially if there is predominantly sensory polyneuropathy, and some of the cases may be associated with cranial nerves involvement, mainly facial nerve, extraocular muscles, and lower cranial nerves. So now we know that case of peripheral neuropathy means distal weakness, lower motor neuron type manifestation, hyporeflexia or flexia, glove and stocking hypothesia. So, what is the etiology of the polyneuropathy? As general, it could be the etiology may be hereditary or acquired. Hereditary causes or hereditary polyneuropathies are less important. Why? Because they are usually not common. They are not common and have no treatment. So we are more interested in the acquired cause. But for the hereditary causes, we have to differentiate between two types of inherited neuropathies. The first type is neuropathies of unknown causes, in which there is an inherited defect of the muscle, whether it's of the nerve. There is an inherited defect of the peripheral nerve, whether there is absence of the myelin, thin myelin, or whatever. This type gets attention from the neurological point of view because the patient will be presented only with inherited polyneuropathy, with positive family history, gradual onset, and very slowly progressive course. The example of this is hereditary sensory polyneuropathy or Charcot-Marie-Tooth. Other types of inherited neuropathies is inherited neuropathies due to specific metabolic or other defect. This type gains an attention of both the internist and the pediatrician because the patient will be affected with peripheral inherited polyneuropathies among other systems. And the best example is the inherited hereditary amyloidosis, in which is amyloidosis of the peripheral nerve. There is also amyloidosis of the liver, amyloidosis of the GIG, amyloidosis of the heart, vertebrate part, skin, and GI skin. So another example is the porphyria. Now we'll shift to acquired causes. As I mentioned, the acquired causes is more common than the inherited causes, and they are considered, the diagnosis is somewhat important because they have treatment. So the acquired causes may be inflammatory, inflammation of the peripheral nerve. Inflammatory causes can be classified into two categories: infective, in which is invasion of the peripheral nerve with microorganism, or immune mediated. For the infective causes, it may be a bacterial, viral, or other systemic. Bacterial, like leprosy, like diphtheria, like botulism, Lyme disease. Viral, like HIV, virus hepatitis, infectious mononucleosis, and cytomegalovirus. Systemic causes like TB, typhoid, chikungunya, and malaria. On the other hand, the inflammatory may be immune mediated, and the best example is the acute polyneuroagiculopathy or Guillain-Barré syndrome, or its a chronic variant, which is a chronic inflammatory demyelinating polyneuropathy or CIGP. We have also systemic causes. It may be due to neoplastic syndrome, connective tissue disease like systemic lupus erythematosus, scleroderma, rheumatoid arthritis, or sarcoidosis. We have metabolic causes like diabetes mellitus, hypoglycemia, renal and hepatic failure, endocrinal disease like hypothyroidism and acromegaly, nutritional disorders like vitamin B1, B6, B12, folate deficiency, drug and toxin-induced polyneuropathies. Drug like, for example, dipenicillamine, isoniazid, most of the cytotoxic drugs. Toxins like heavy metal toxins like lead intoxication, mercury intoxication, arsenic, and thallium. We have also industrial and agricultural poison like organophosphorus compound. Other causes may include patient with chronic occlusive peripheral arterial disease or chronic ischemia, patient with chronic obstructive pulmonary disease, patient with critical illness insufficiency. So these are plenty of causes. So how to diagnose a case of peripheral neuropathy? The diagnosis occurs in two steps. The first step is to localize the lesion to the peripheral nervous system and exclude other possibilities. As I mentioned, peripheral neuropathy means pains, numbness, paresthesia in hands and feet, glove and stocking hypothesia, distal weakness, iflexia. Exclude other conditions like spinal muscle, for example, distal myopsis, like plexopathies, like anterior horn cell disease, spinal muscular atrophy, motor disease, or shock stage of transverse myelitis. The second step is to diagnose the cause of peripheral neuropathy. So we have to diagnose this is a patient with polyneuropathy. Then, what is the cause of the peripheral neuropathy? Some helpful points that may help us to diagnose peripheral neuropathy. The cause is the polyneuropathy is predominantly motor or sensory. We don't have a pure motor neuropathy and we don't have a pure sensory neuropathy. But we have a pure motor neuropathy and we have a dominant motor polyneuropathy and a predominantly sensory polyneuropathy. Predominantly motor polyneuropathy and causes include Guillain-Barré syndrome, botulism, diphtheria intoxications, Lyme disease, infectious mononucleosis, systemic lupus erythematosus. Predominantly sensory polyneuropathies causes include diabetes mellitus, nutritional vitamin deficiency or alcohol, amyloidosis, hereditary sensory polyneuropathies, Fabry disease, renal failure, and neoplastic syndrome. So, the first step was, which is predominantly motor, predominantly sensory. Second, we do a peripheral nerve conduction study. If we have a marked reduction of the conduction velocity, this is demyelinating polyneuropathy. If the conduction velocity is normal or slightly reduced, this is an axonal neuropathy. Demyelinating neuropathy, the only diagnosis I want you to remember is Guillain-Barré syndrome or acute inflammatory demyelinated polyneuroagiculopathy. Axonal neuropathy, most of the causes, toxic causes, metabolic causes, are usually toxic. Metabolic causes usually causes axonal neuropathy. The rest of the diagnosis will depend on the investigation. We have to do a nerve conduction surgery, needle imaging. Sometimes we need to do a sure nerve biopsy. Laboratory investigation including ESR, C-reactive protein, CBC, hepatic and renal function tests, thyroid function tests, vitamin B12 levels, screening for cholinergic screening for tumor markers, and other tests according to what you are suspecting. Now we are going to take examples of mainly motor neuropsis and mainly sensory neuropsis. For mainly motor neuropsis, best example is Guillain-Barré syndrome, or we can say it's a acquired immunologically mediated demyelinated polyneuroagiculopsis, or AIGP. By definition, it is an acquired immunologically mediated polyneuroagiculopsis that developed over a period of days or weeks, but no longer than 4 weeks. If we look at this diagnosis, so the first part of acquired immunologically mediated polyneuroagiculosis. Acquired immunologically mediated, this means that it is an inflammatory process, but it is not infective. It is not due to direct invasion by microorganisms. It is immunologically mediated or post-active. So in the majority of the cases, in a 50% to 2/3 of the event, there is a history of preceding infection, which occurs usually 1 to 4 weeks before the onset of the paralysis or weeks. The preceding infection will be in the form of gastroenteritis or the form of upper respiratory tract infection. And there are certain organisms that are linked to the pathogenesis of Guillain-Barré syndrome, like Campylobacter jejuni, Mycoplasma pneumoniae, infectious mononucleosis. The preceding infection trigger immune mechanism that lead to the formation of antibodies that react with the peripheral nerves. This is what we mean by acquired immunologically mediated polyneuroagiculopsis. The second part, polyneuroagiculopsis that developed over a period of days or weeks, but no longer than 4 weeks. This means that the infection or the inflammation is an ascending. So you may be confronted with a patient with mild manifestation, just Glavin-Stokes, mild weakness, but he can walk without assistance. And in the next few days, the weakness progresses to involve more proximal muscle, involve the upper limb, and involve the respiratory muscle. So the second part of the definition, which means that a polyneuroagiculopsis that develop over a period of days or weeks, this means that it is an ascending disorder. But no longer than 4 weeks, because if the progression extends more than 4 weeks, this is no more an acute, it becomes a chronic. So it is not more an acute inflammatory polyneurosis, but it is a chronic variant. So this is what we mean by acquired immunologically mediated polyneuroagiculopsis that developed over days or weeks, but no longer than 4 weeks. If we talk about the etiology, pathology, and pathogenesis, we already give some point. So there is a history of preceding event that trigger immune reaction, immune response, lead to a formation of antibodies that react with the peripheral nerve myelin. Pathologically, there is loss of myelinated fiber, there is endoneurial perivascular inflammatory infiltrate, which is formed mainly of mononuclear cells, lymphocyte, plasma cells, and there is multifocal segmental demyelination affecting any part of the peripheral nerves, starting from the roots up to the intermuscular branch, with the main lesion occurring usually is anterior-ventral roots. That's why the disease or the weakness of the disease is mainly motor, because it mainly affects the anterior-ventral root more than the dorsal roots, and the weakness is not only distal, but sometimes it is distal and proximal. Clinically, the patient will be presented with weakness, which affect both upper limbs and lower limbs. More commonly, it starts in the lower limbs, then in the next few days, it extends to involve more proximal muscle and extend to the upper limbs. The weakness may extend to the pelvic girdle muscles, to the trunk muscles, to the shoulder girdle muscles, and more seriously, it may affect the respiratory muscles, lead to respiratory impairment that necessitate mechanical ventilation. The weakness is symmetrical bilateral, affecting the limb distally and proximally, and sometimes it is as severe proximally as distally. The weakness is a flow of motor neuron types, so it may be associated with aphyxia and hypotonia. Sensory manifestation is usually mild in the form of short Glavin-Stokes hypothesis. The patient may be associated with some autonomic manifestation. Some patients may have cranial nerve involvement, especially the facial nerve, which may be affected bilaterally. The extraocular muscle lead to ophthalmoplegia. The lower cranial nerve nuclei lead to dysphagia, shocking attack. Very rarely, the weakness may extend proximally and may even affect the spinal cord. This is a diagram to demonstrate that the weakness is not only distally, but it is proximally as well. Some of the patients may have flaccid paralysis and be confined to a wheelchair. Diagnosis depend on, first, the clinical picture. Second, CSF. CSF will demonstrate what we call protein cell dissociation. Cells are normal because this is an immune mediated, it's not infectious. Protein is highly elevated. By the word highly elevated means that it is usually about 300, 400, or even 600. The protein cell dissociation, this means that usually is characteristic for patient of Guillain-Barré and usually it appears 1 week from the onset of the witness. Second is by nerve conduction study. This is a related disorder, so there is a marked reduction of the conduction velocity, prolongation of the cell latency, and the prolongation of the F wave latency. Third, very rarely we may need to do actual nerve biopsy. Fourth is usually by asking for complement, looking for by serology, looking for complement fixing antibodies against peripheral nerve myelin or immunology to demonstrate the preceding infection. Treatment of Guillain-Barré, the first thing we have to know that the patient should be hospitalized for the whole period of expected duration of the expected deterioration. The patient should be hospitalized for the whole period of expected deterioration. So you may be confined to the patient with mild weakness and he can walk without assistance. This is a mild patient, and you may discharge him home, and he will come to you again after a few days with flaccid quadriparesis and even respiratory impairments. So whenever you suspect the patient is a case of Guillain-Barré, you have to admit him in the hospital for the whole period of expected duration. By definition, it is 4 weeks, but usually most of the patient will deteriorate in the first 2 or 3 weeks. So you have to keep the patient in the hospital for at least 3 weeks from the onset of the illness, with close monitors of the respiratory function, the heart rate, the blood pressure, and the electrolyte. Some of the patient may be bedridden, so they will need the usual care for a bedridden patient. That's to say, care for the eyes, care for the skin, care for the nutrition, care for the sphincters, and a prophylactic dose of unfractionated heparin for guard against deep vein thrombosis or pulmonary embolism. Heparin 5,000 units subcutaneously every 12 hours. The actual treatment is either plasma exchange, plasma apheresis, or intravenous immunoglobulin. Plasma apheresis, which is 4 to 6 sessions, given alternate day basis, or alternatively we can give IVIG, intravenous immunoglobulin, given for a dose of 2 grams per kg, divided over 5 days. This treatment is expensive and not without hazard, so it has to be limited to a moderate or severe cases. Mild cases should be managed conservatively. Mild cases will mean that patient who can walk without assistance. This is a mild cases and should be managed conservatively with careful watching or follow-up. Moderate to severe cases, once they start to need assistance, this should be treated with either plasma exchange or IVIG, and there is no role for corticosteroid in the treatment of Guillain-Barré syndrome. The second point, or second topic I'm going to speak about is diabetic neuropathies. Diabetes could affect the peripheral nervous system in different ways. The most common pattern of affection of the peripheral nerve is diabetic distal symmetrical sensory predominant polyneuropathy. Patients with long-standing diabetes, especially if they are uncontrolled, usually suffered from paresthesia affecting feet and later on affect hands, and sometimes it is burning sensation, and sometimes it may interfere even with sleep. This may be associated with decreased deep tendon reflex. Usually the motor power is preserved. Another example is diabetic ischemic mononeuropathy. This means that on top of distal symmetrical sensory predominant polyneuropathy, patient may develop acute or subacute onset of hand drop, foot drop, facial nerve palsy. This is ischemic mononeuropathies, which usually related to uncontrolled diabetes, and usually this part have relatively good prognosis, usually improved with conservative treatment and adequate control of the blood sugar level. The third is diabetic autonomic neuropathy. Patient may have post long-standing cases of diabetes mellitus, may have postural hypotension, may have GIT disturbance, may have decreased sexual potency or impotence, أو بنسمع sphincteric disturbance. Another بنسمع حاجة pattern of involvement of the peripheral nervous system is compression and entrapment syndrome. Compression and entrapment syndrome, some of the nerves may be entrapped as they pass through a nerve tunnel. For example, The medial may be interrupted at the wrist as it runs or it passes under the transverse carpal ligament. This is what we call carpal tunnel syndrome. The ulnar nerve may be interrupted as it winds around the elbow, or cubital tunnel syndrome. The peroneal also nerve may be interrupted as it winds around the fibular head. Or the lateral cutaneous nerve of the thigh may be interrupted as it passes under the lateral end of the inguinal ligament, lead to myalgia basica. Interrupted neurosis occurs in any patient, especially obese patient or patient with joint problem, but it is particularly common in diabetes mellitus. Why it is common in diabetes mellitus? Because diabetes is usually associated with impairment of the peripheral circulation, and it may be associated with synovitis or tenosynovitis or fasciitis. The last pattern of peripheral nerve involvement in diabetic patient is what we call diabetic amyotrophy or diabetic radiculoplexus neuropathy. We use that diabetes usually, or the diabetes affects the peripheral nerve distally more than both. But in this pattern, patient with uncontrolled diabetes, for long duration of uncontrolled diabetes, may have developed weakness and pain, which is usually in the anterior and the medial compartment of the thigh. This may be unilateral, may be bilateral, and even which is bilateral may be asymmetrical. In the past, we consider that diabetic amyotrophy is the result of diabetic ischemic mononeuropathy affecting the femoral nerve and the obturator nerve, but this has not been documented. The pathology may be in the roots or in the plexus, so it is now named as diabetic amyotrophy, diabetic radiculoplexus neuropathy. And the most common is the lumbosacral variant, but we also have thoracic radiculosis or cervical form. How to treat the most common type of diabetic distal symmetrical sensory-predominant neurosis? This is usually adequate or tight control of the blood sugar level is essential. This is help to delay the progression of the involvement of the peripheral neurosis and limit its progression, but will not reverse the damage that already happened. Most of the treatment of diabetic neurosis is symptomatic, and the most common problem in diabetic patient or diabetic neurosis is the pain, which sometimes is challenging. Treatment of diabetic painful neurosis or pain in diabetic neurosis, sometimes it is difficult and challenging. We may start with simple analgesic, non-steroidal anti-inflammatory drugs. We use antifibrilliptic drugs like gabapentin, carbamazepine, oxcarbazepine, and finally we may use antidepressant like amitriptyline, like tricycle antidepressant or amitriptyline, use of selective serotonin uptake inhibitors, and more recently we can use selective serotonergic noradrenergic uptake inhibitors like duloxetine. The last item I'm going to speak about is the interrupted neuropathy, and the most common types of interrupted neuropathy is the carpal tunnel syndrome. Carpal tunnel syndrome, this means that interruption of the median nerve as it passes below the transverse carpal ligament. This is the most common type of interrupted neuropathy, and it affects about 1% of the population, more common in females. Patients will usually complain of numbness and pain in the median nerve distribution in the hand. This بالنسبة حاجة may be okay throughout the whole day, but it is usually more common due at night and sometimes may interfere with the patient's sleep. On examination, there is usually significant sensory loss hypoesthesia in the median nerve distribution of the hand. Post-tenal test, that's to say, tapping of the median nerve at the wrist may elicit pain that may extend through the ulnar median nerve branches in the hand. Very neglected cases might find atrophy of the abductor pollicis brevis muscles. The pain is usually in the hand, but sometimes it may extend to the forearm or arm, and the patient may even complain of brachialgia. Diagnosis depends on the nerve conduction study to demonstrate the delay in the conduction velocity of the median nerve in the transcarpal segment. Treatment is usually conservative treatment by giving simple analgesic or anti-inflammatory drugs. Sometimes we may use aspirin. Sometimes we may use local injection of steroid or local anesthetic, and finally surgical decompression. Thank you for your attention.